Hello, everyone. Welcome back to a new episode of Skin to It, your guide to healthy skin.
I'm Marla, fashion stylist and beauty enthusiast.
And I'm Dr. Sandy Skotnicki, your trusted dermatologist.
Today, we're diving into an exciting topic.
We're going to break down everything you need to know about menopause with Dr. Marla Shapiro, an international menopause expert. And I want to thank Galderma, a global leader in dermatology committed to advancing skin health, our sponsor for this episode. With innovative solutions for skin changes during menopause, Galderma helps women feel confident and comfortable in their skin.
So grab your notepads and let's get skin to it.
So today we have a really great episode. Thank you all for tuning in again. We are taking a deep dive on the most important and really an evolving and trending conversation in women's health, menopause. Its impact on the skin, our well-being, and long-term health. And we have a very special guest with us today, Dr. Marla Shapiro. And I'd also like to thank Galderma, a global leader in dermatology, for helping sponsor this episode today. So just a little bit about Marla. First of all, Marla, thank you for joining us.
My pleasure. One of my favorite topics. We spend more than 1/3 of our lives in menopause, so we need to be educated about it.
You are so right. So Dr. Shapiro completed medical school at McGill University and trained at the University of Toronto for her Master's of Health Science. She concluded her specialty training in community medicine, receiving her fellowship in preventative medicine and public health from the Royal College of Physicians and Surgeons in Canada. She also holds a fellowship in family medicine and is currently a full professor in the Department of Family and Community Medicine at the University of Toronto. She is a medical expert for CTV and is seen on CTV News Channel. She's also the author of a best-selling book, Life in Balance: My Journey with Breast Cancer. She's a member of several advisory boards, including the Terry Fox Institute, and she was the president of the North American Menopause Society in 2017 and currently sits on the board of trustees for the International Menopause Society. In 2015, Dr. Shapiro was named as a member of the Order of Canada, congratulations, for her contributions as a family physician and a trusted source of health information. One of the country's highest civilian honors, the Order of Canada recognizes outstanding achievement, dedication to the community, and service to the nations. What a better guest we could have. We couldn't have had a better guest for menopause. So thank you so much for being here.
Thank you, Marla. So I just want to say I'm so happy to have you on because I have been a patient of Marla since I was, I think, 16. My mother was a patient of Marla's. Her friends were patients of Marla's. And my daughter is also a patient of Marla's. So she has been treating, as we just said earlier, 3 generations in my family. And yeah, you've seen us through a lot. A lot.
I have some 4 generational families. I don't know what that says for my age, but it's really an honor when family members bring family members and you have healthcare across generations. So
yeah,
I'm seeing a little bit of that. I'm approaching 28 years of practice, so I'm starting to see kids that I saw as young teens having kids of their own, and bringing them in to see me. It's really lovely.
Yeah, it's really beautiful. Okay, so my question. Well, first, I want you to tell us about your journey from family medicine at the University of Toronto to becoming one of Canada's leading voices in menopause and women's health.
Well, I think one of the wonderful things about family medicine is that it opens up the doorway of opportunity for so many different interests. And early in my career, I went to the North American Menopause Society meetings. They were, I think, in Chicago, the first meetings that I went to. And it was on midlife women's health and beyond. And I realized that was an area that I really wasn't trained in. And to this day, the menopause training is lacking in medical schools across the nation, across the world. And it really was an unmet need. And it was unbelievably fascinating. And I became more and more involved in, not only family medicine in general, but really had a special interest in women's health from midlife and beyond. And anything that you can think of, not only just immunization, but cardiac health, bone health, the management of menopause. It's just so broad, and women are often the caregivers and the care providers, don't necessarily identify themselves as needing care or prioritize themselves. And sometimes at midlife, when kids are leaving, I mean, you're at that stage, Marla, where kids are leaving you, really.
Yep.
It opens up the doorway to recognize that it's never too late to take care of yourself, develop interests, take care of your health. And so it sort of was a natural evolution for me to go in that direction.
So, this is a podcast on skin and skin health. And sort of before we get into that, because we do want to talk about the effects of menopause on the skin. So you mentioned NAMS, which is the North American Menopause Society. And what are your thoughts? I've learned that some doctors are going back and getting I think it's a 1-year certificate on NAMS. Do you think that's enough?
So it certainly is a start. So the North American Menopause Society has rebranded itself to the Menopause Society. There's also the Canadian Menopause Society. And as you mentioned, I sit on the board of trustees of the International Menopause Society. And all those organizations are very, very targeted at broadening the scope of education for not only the lay public, because we have sites for women that is designed for women to understand and read and become empowered on a vetted website, not a website that's trying to sell you something.
Right.
And the Menopause Society does have a credentialed program that you sit a certificate for. You sit an examination to become a credentialed menopause expert. And on the International Menopause Society, we also have a series of modules for physicians to really become educated. So it's one route at which you can expand your knowledge and become more expert in the area. So it certainly is a beginning. And then for all of these, in order to maintain your credentialing, you have to have so many hours of menopause training per year. So I think it's a great way to open up that doorway to education for practitioners and nurse practitioners, nurses, pharmacists.
Right.
All comers are welcome.
So can you highlight for us, I guess, the major points that, like, what people are actually, how would you say this?
Well, from the 2022 NAMS, because I mean, obviously the positions have changed since the initial study, that big one in 2002, the Women's Initiative Study. So the 2022 position statement that just came out from NAMS, what are the highlights of that?
So it's really been, it's not so much that we've changed. We've evolved as the science has changed. The Women's Health Initiative that you referenced back in the early 2000s did a huge disservice to women. And in a nutshell, the reason that it did is because we recognize that the window of opportunity, and it really is a window of opportunity to treat women who require treatment or need support through their journey in menopause. Remember, menopause isn't a doorway. You don't go through and you're done.
Right.
You live the rest of your life in menopause.
It's a long marathon as far as I'm finding.
It's a long marathon, long journey. And you want to do it as healthily as you can. And we recognize that for women who go on menopausal hormone therapy, there's a window of opportunity when it is safest to initiate. And that's in the first 10 years following your last menstrual period, the first decade of menopause. So what has evolved over time was when that study was presented, 2/3 of the women in that study were age 63.
Right.
We don't initiate women on menopausal hormone therapy at age 63. They're past the window of opportunity. Only 1/3 of the women in this study were in the window that we actually treat.
Did you say 1/3?
Well, only 1/3 of the women were under age 63.
Right.
2/3 were over age 63, 70s, 80s, and so on. And many of them had previously had menopausal hormone therapy. So they're not representative of who we treat. And when the data was presented, it was presented like all the women. And we recognized very quickly that women in their 50s versus women in their 60s versus women in their 70s carry their own innate risks, if you will, based on age alone. So you can't take all those women and pool them together and get a result and say, oh, this applies to me. So as a result, the notion of individualizing therapy has become very important. So it used to be the lowest dose for the shortest period of time. That was a real disservice for women. Women thought they could only be on treatment for 5 years and had to stop. Now we talk about the individualized route, meaning the dosing, the formulation. Is it a pill that you take? Is it a transdermal gel? Is it a patch? They're all very different for the appropriate length of time for the appropriate woman. So I'm always saying to patients, it's nice that you talk to your girlfriends about what they're doing, but they are not you.
Right.
And we're gonna have a focused conversation about you, your risks, your individualized background, and what may be best for you. Because choosing medication and choosing therapy has to be individualized. So we've evolved and we recognize that still menopausal hormone therapy is the gold standard for women who are suffering.
Mhm.
We have new exciting medications that are out there now. Our first non-hormonal medication that's been studied in a large randomized clinical trial for hot flashes, because we now understand that hot flashes start in the brain. So we know where the brain
Wow.
trigger is for hot flashes. So much has happened. It's such an exciting field to be in. So the position statement really is all about individualization. And for me in my practice, it's not only about individualization, but it's about a partnership. It's
Mhm.
about, there's no point me initiating something that you don't want, that
Right.
you're
Right.
even throw out the prescription. What's that all about? It really is about a partnership to try and decide, what are your unmet needs? What is your background history? What's your family history? What are your individual risks? And how can we best serve you as an individual for what you're identifying as your concerns?
So I have two questions off of that. So because I did read the NAMS briefly as a physician, I looked through it. You've alluded a couple times to if women have symptoms. So let's actually review that, because some of the NAMS is like if you have vasomotor symptoms, which is basically, flushing and sweating, right?
Yeah, that's what it is. Hot flashes
Hot
and
sweats, yeah.
yeah.
And, sort of the brain fog thing, loss of bone mass. What other symptoms would, like, because some women, I think the majority nowadays know, okay, this actually could be from menopause. I mean, I think the sort of mental brain fog is not necessarily that well, like, is this a symptom?
So,
Yeah.
estrogen impacts every part of our body, including skin. It has
Mhm.
a huge impact on skin,
Yeah. We're going to
on
get to
our
that.
brain. We
Yeah.
know that there are estrogen receptors in pretty much all of our tissue. And we know that in perimenopause, when estrogen begins to fluctuate, that that brain fog that women talk about is really related to the fluctuations and the loss of estrogen. And generally it will plateau out, over a couple of years or so. So women can be reassured that this brain fog is going to get better. Mood changes in and around not only menopause, but all periods of time when estrogen fluctuates. So
Mhm.
adolescence,
Mm.
postpartum,
Right.
estrogen is linked to mood as well. So loss of estrogen gives you accelerated bone loss. That's why we talk about osteoporosis in women being a postmenopausal
Mhm,
event.
mhm.
Hmm.
Uh, Joint pain is very common in estrogen depletion. So, and the hot flashes and the night sweats. We also know, and we're learning, which is unbelievably fascinating, that women who really suffer with hot flashes, it's a marker of cardiovascular
Yeah.
disease and cardiovascular risk. So, estrogen is
Really?
innately
Yeah.
related to, you name an organ, it has an impact. And what many women also don't know, because it happens much later in the menopause transition, is vaginal dryness and
Mhm.
what we call genitourinary syndrome of menopause. Women often don't associate it with the estrogen loss because their hot flashes may even have gotten better at this point, but they are now experiencing vaginal dryness. It's related to low estrogen. All women will have it. Not all women will suffer with it, but all
Mhm.
women will have it. And while we talk about the mean length of time being about 7.5 years for hot flashes, about 10% of women are in their 80s and 90s and never lose their hot
Yeah,
flashes.
I've
Oh
heard those
gosh,
stories. So
I can't imagine.
so just to come full circle, sorry to
Yeah, no, no, no.
like, so when you say the NAMS 2022 position statement is if patients have symptoms, all those things you
Yeah.
just rhymed off, those would be indications.
No,
Okay,
only one.
only
The
one.
only indication for menopausal hormone therapy or non-hormonal menopausal therapy, now that we have that, is intractable hot flashes and night
Okay.
sweats that women are suffering for. But we don't, if women don't have hot flashes and night sweats, even though we know that estrogen offers an element of cardiac protection and bone protection, we don't use it for disease prevention in general. We do use vaginal estrogen and other vaginal options for women who are suffering with vaginal dryness, so we can use that forever. But the indication for pharmacological therapy is usually the hot flashes and night sweats. It's not
Right.
the
Not
skin.
for the
It's not.
other.
So that's important, because
That's
I think a lot of people don't understand
understand
or
that.
realize that. I mean, did you? I mean, yeah, I did. But okay, my next question is, because, and I'm going to tell you about my own sort of little personal journey, is the bioidentical hormones. It was interesting for me to read in the position statement that,
Yeah.
it certainly has some benefit, but the problem and the reason it's
No,
not
no, no,
really
no.
recommended.
Let's stop right there.
Okay,
Right there.
all
Okay.
right,
Bioidentical became a marketing term that was coined by the so-called alternative healthcare market.
Right.
The fact is that I use the word in my practice, body identical. The notion of bioidentical is nonsense because anything that's processed is not identical.
Okay.
Body identical. If you're on thyroid medication, that's body identical to the thyroid hormone that your body made if you don't make enough thyroid hormone. If you require insulin, that's also body identical to the insulin that diabetics don't make. So we have many body identical hormones that are pharmacologically available that have been studied in large randomized clinical trials. We know their safety, we know efficacy, we know dosing, we know routes. So there's absolutely the notion of a custom compounded bioidentical hormone is all about marketing. Because when you have a so-called custom compounded, there's no quality control.
Right.
You don't know what you're getting from dose to dose.
Yeah.
You have an intact uterus. You don't only need estrogen, you need some agent to protect the lining of the uterus because estrogen on its own can cause the lining to grow and lead to issues.
Right.
If you don't have a uterus, it's different. So there's really no role for this notion of custom compounding because there's nothing custom about it. There's nothing, and measuring your hormones after menopause is nonsense because you don't have any. So there's nothing to measure.
Yeah.
So the notion that we can measure and do something that's custom for you, we have, for example, estradiol, which is what our body made before we became menopausal, available in multiple doses. So I can work with you and individualize your dosage or custom your dosage, if you will. But the notion of custom compounding bioidentical hormones led women to believe that it's natural and therefore is safe without any side effects. In fact, we have lots of studies that show that women have adverse events, including thickening of the lining of their uterus because they don't get enough protection or aren't absorbing enough of this through the skin preparation. And there's no control. Because it's not regulated the same way medication is regulated. We don't have safety, efficacy. We don't have data on any of these things. So if you want to be treated with something that is body identical, or you want to call it bioidentical, I can do that with a pharmacological product that I know about its safety, its efficacy, its packaging, and all of those kinds of things.
Yes.
So that's the point of the statement, saying that don't fool yourself into believing that if someone tells you they're custom compounding, that this is going to be safe and cannot lead to breast cancer, can't lead to stroke, can't lead to heart disease. It's without side effects. That's not true. It's just not true.
So let's just have some conclusion here. You individually and also the society are not for bio or body identical hormones.
We're for body identical hormones. We're not for the notion of custom compounding bioidentical.
So I think, again, if I'm having trouble understanding that as a physician, so you're not...
all of these hormones that you're talking about, estradiol, progesterone, they're body identical. They're the ones that go into the so-called custom compounded. I'm going to make this for you. I'm going to make it cream. When our pharmacists are regulated, and there is a lot of roles for compounding when a medication is available or a patient needs a delivery system that isn't available any other way. Compounding does have a role in the practice of medicine. I do
it all the time in dermatology. Yeah. So
absolutely. So there's a huge role for compounding when there are no other alternatives that are safe and effective. The point that we make as the International Menopause Society, as the Canadian Menopause Society, as the Menopause Society in the United States, all the Menopause Society, is that to lead women to believe that if we put a lotion, a potion, a cream together that would have some compounding, that it's safe and without alternatives and without side effects is not true. If you want a so-called body identical menopausal hormone treatment, you can do that with medications that are studied, and we know their safety, their efficacy, and their dosing, and we know exactly what we're giving you. We don't know exactly what we're giving you when someone
is mixing it.
Exactly.
So I think we have the answer to that.
So I'm not on hormone. I'm not on hormones. I'm not taking any hormones. I had, except for the Imvexy for vaginal dryness. That was really my only symptom.
Right.
So that's hormonal therapy.
Yeah.
Right. So the difference with that is, in terms of the route of administration, when you have a vaginal estrogen product or a comparable estrogen equivalent that we're using per vagina for dry vaginas, the dosing is in micrograms. It is so low. There is virtually no systemic absorption into the bloodstream. I can't measure it if I went in. So it works locally. It's a local, and we also have an oral therapy that's used for women who don't like the idea of inserting anything into their vaginas. We have an oral therapy called aspemifene that women can take. And these are specifically designed only for the genitourinary syndrome of menopause. For example, women postmenopausal who often have repetitive bladder infections, it's often because they lack estrogen. There's estrogen receptors in the bladder, which we deliver per vagina, low dosing. And that is a form of vaginal therapy, but it's not systemic. Won't do anything for hot flashes, night sweats, bone health, none of that stuff. It's only for one indication, and that's for the genitourinary syndrome of menopause and vulvovaginal atrophy, which we got rid of that term because nobody wants to be told they're atrophic.
Oh no, that's the worst. That was the worst.
The one that Marlo is on, is it estradiol or
estradiol?
Estradiol. Okay.
In other words, that's a body identical or bio or whatever you want to call it. It's a 10 microgram, also comes as a 4 microgram. It's a 10 microgram vaginal estrogen, tiny little ovule that's inserted per vagina and is absorbed locally, not
And is it synthetically made, or where's it coming from?
Estradiol these are usually plant derivatives, but everything is synthetically made.
Well, of course, but I mean, like, I always think, I mean, I'm really talking about a topic here that I don't know a lot about. Like, Premarin, I thought was from horses. I mean, is that okay?
Premarin is conjugated equine estrogen, and it's one of the most studied estrogens of our time, inordinately safe. In fact, we know that it's one of the most breast-friendly estrogens that is out there, conjugated equine estrogen. But that's why it was called Premarin, from pregnant mare's urine. That is exactly where it comes from. You're not incorrect.
You're
right on that. Yeah.
So, but the one that Marlo's using vaginally is a plant-derived estradiol.
It's an estradiol. And Premarin, we also have Premarin vaginal cream.
Yes.
Which is also used for exactly the same indication. And these are all safe and effective and really very useful for many women who, are suffering, have either discharge or painful intercourse because of dryness. And for my women who aren't sexually active, we don't want to not talk to them about this and say, oh, this is not just about painful sex. This is about vaginal discomfort. This is about burning. This is often about repetitive urinary tract infections. So all women.
I have a question. It's actually sort of a personal question, but like, I don't have anything because I've never really had symptoms. I don't have, like, I really have sort of, other than I think I had some brain fog, but if you, and this is a question for all the listeners, like, so let's say you have sort of missed the boat. You haven't had a lot of vaginal dryness, you haven't had a lot of symptoms, and then all of a sudden you do, but you're like 6 years, 7 years into menopause.
You're still in that window.
Is it too late though? Is it ever too late? Like, because I know we don't like the term atrophy, but there is going to be some vaginal atrophy. I mean, I think about the skin, like outside.
Well, it's just like skin.
It's just, well, it is. It's a mucosa. But if you're too late, should you be starting the creams in the vaginal area before you get symptoms? Because I mean, I love Peter Attia. He talks about medicine 2.0. Don't wait to have symptoms. Start before you actually get the symptoms. What are your thoughts on that?
So we know that for women who have marked atrophy, and those women often are our breast cancer patients who are on medications that give them marked atrophy, we know that they can get a little bit of estrogen absorption at the beginning because the lining is so thin. The thinner the lining, the more likely you are to have absorption. Earlier is better. There's no question that earlier is better.
But if you're not having symptoms, like, why would you start?
Eventually you will.
Eventually, well.
No, I know that, but I mean, so my question is, should you start earlier?
It's easier to maintain than it is to
attain.
Yeah. It's definitely easier to maintain than it is, but we start based on need. So often I'll examine a woman. I'll say, are you symptomatic? Like, are you having any difficulty? And I'll point out exactly what the symptoms are, because often they don't even know what the symptoms are.
Exactly. What the symptoms are.
Yeah. So I'm very specific about what the symptoms are, because I can see that the tissue is atrophic. I can see that, and I will often tell them, you're getting signs. And often women, when will they really notice this, is if I'm going to do a pap test and they're really uncomfortable. It's because they have lost the normal vaginal secretions that we have in the presence of estrogen and all that glandular tissue. So it's always better to maintain than it is, as you say, to attain.
Can we talk about some non-hormonal strategies for managing the symptoms, menopause symptoms?
In terms of what's available non-hormonally, when it comes to things like lifestyle, weight loss, exercise, good sleep, yoga, that's wonderful for you. Not going to do a thing for your menopausal symptoms.
Oh gosh. Okay? Nothing?
Not even the sleep? Come on. No?
Sleep's good for everybody,
Yeah.
but and chronic insomnia is a big concern for postmenopausal women and
Yeah.
perimenopausal women. It's really a big issue. But the bottom line is that those do not make a difference. Even avoiding so-called triggers, like women who say to me, I have a cup of hot coffee, I get a hot flash. I have red wine, I get a hot flash. We don't have any science that tells us if you avoid the red wine or you avoid the hot coffee or hot tea, that it's going to avoid the hot flash. If you notice cause and effect, then by all means, make those changes. None of those are harmful changes to make. The only thing that works in terms of strategies is cognitive behavioral therapy. So that's therapy that you get with a behavioral therapist who teaches you about coping and about challenging unhealthy beliefs. That has a lot of impact. Hypnosis may have some impact. There's no evidence that acupuncture has any impact at all. In terms of other non-hormonal, so that's lifestyle and things that you can do.
Right.
You know, it's great to do yoga. It's great to do mindfulness. It's great to be all of those things, but it's probably not going to do a thing for your hot flashes. Whereas medication that's not hormonal, almost everything that we've used up until now has been off-label. So what do I mean by that? Low-dose antidepressants are effective for some women to get rid of their hot flashes or night sweats, or at least bring them down to a level of decreased frequency and less severity. But I say they're off-label because they were studied for use in depression. They've never really been studied in large randomized clinical trials for menopause, so they don't have an indication, meaning on the label, this is good for menopause, but you can use low-dose antidepressants and some women it will be very effective. And some women won't make a difference, but some women it will be very effective. We used to use a medication called clonidine for blood pressure that was found to help. We don't use that much anymore. And in older women, we worry about cognition, brain health. We use gabapentin. Gabapentin can be used at nighttime and is very useful for women with hot flashes. That was never studied for women with hot flashes, but it's been useful. It has sedation as a side effect, which is why we use it at night. So there are different medications that have not been studied for menopause that are used in menopause, but now we have our first on-label medication. It's fezolinetant, marketed under the name Veozah, and Bayer has a product called elazinitant that will soon be approved as well, that works in the brain on the receptors, neurons of the hypothalamus, which is an important part in your brain, where your temperature control is. We now understand the pathophysiology of a hot flash. Estrogen keeps that thermoregulatory zone neutral so that women don't get hot flashes premenopause. But in the absence of estrogen, you start getting those wacky hot flashes and night sweats. We now can work at the level of the brain with these medications that are not hormones, so they don't have that same issue in terms of the window of opportunity, the aging, and that we talked about with menopause hormones.
Is that available in Canada?
Just been approved and making its way to the shelves right now.
Okay, so patients
can approved in Canada, approved in the United States. The United States was the first to approve it. Approved in many countries in Europe. I just came back from the European launch in Vienna talking about the clinical trials. So it's very exciting.
And is it expensive for people that don't have a drug plan?
What do you think?
Yeah, very expensive. Right.
All of these medications are expensive and not covered in terms of our Ontario coverage. So, yes, there's no question that these medications are expensive, but they're life-altering. They really are life-altering for many women.
So we're going to move on to bone and heart. And I mean, I know you just said at the onset that hormone therapy for menopause, the only indication is the vasomotor, the hot flashes. So outside of that, I mean, I was reading on some of the more, not controversial, but interesting, like I'm actually on metformin.
Right.
500 milligrams a day. Maybe low dose Ozempic, like things that may affect the cardiovascular osteoporosis effects. Like these are controversial things that I came across in menopause. What are your opinions?
None of those will do anything for your bones. Ozempic doesn't do anything for your bones.
No, but just outside of maybe cardiovascular, maybe we're talking cardiovascular. So just talk about other things that you can possibly do for menopause, osteoporosis and the cardiovascular risk factors that are associated with menopause that aren't hormone therapy driven.
So let's take each one in turn. Let's talk about osteoporosis first. I like to say that osteoporosis, starts like in our pediatric world, we need to be thinking about having a bone plan for our later years because we build our bone mass in the first 3 decades of life. So
Okay.
calcium and vitamin D intake is critical in our children, but we forget about calcium and vitamin D as we get older. We've learned that calcium is a threshold vitamin. Some is good, too much is not. And that you're far better off to get calcium as a woman in your diet. And we require about 1,200 milligrams a day. I tell most women, most Canadians get about 500 milligrams in their diet, and then start adding up your dairy sources to see if you get the remaining 700 milligrams in your diet. But certainly women don't need a 1,200 milligram calcium supplement.
Yeah.
They're already getting some calcium in their diet. You need to do the math to figure out, do I need a calcium supplement?
Right.
All Canadians need vitamin D. All of them.
Right.
Even if they're not wearing sunscreen, they need vitamin D.
Yeah.
We don't absorb vitamin D, and vitamin D is a fat-soluble vitamin, which means it's better taken as a sublingual, under your tongue dropper, so you absorb it directly into the bloodstream, than a pill. If you're taking it as a pill and you take it first thing in the morning when you brush your teeth, you're probably just getting expensive urine. So you need to take it with a fatty meal if you're taking it as a pill, so avocado or olive oil, but vitamin D is fat-soluble. It doesn't absorb well on an empty stomach. So that's calcium and vitamin D. Exercise, weight-bearing exercise, critical for bone health. Aerobic exercise, critical for heart health.
Right.
So exercise is critical for both of them. So those are the things that you want to do to build your bone mass during your growing years. So you want to tell your daughters this because it's so important. If you've got granddaughters, you want to tell your granddaughters this, that milk is cool and you need to be drinking milk, and you can get, all types of calcium supplemented dairy products. So we want to be doing that. And low fat dairy is very good for all of it, this heart health, bone health. If you do we don't screen in terms of a bone density test until age 65, because women before that are very unlikely to have low enough bone mass that they're going to fracture. And we're really looking for risk for fracture. That's the most important thing. One of the biggest risks for fractures are women who fall. Family history, if you had a mom or a father who had a hip fracture, that's not good for you because osteoporosis does have its roots genetically.
Yeah.
And then there are medications that are specifically designed for treatment of high risk for fracture. Lots of different medications, oral medications, injectable medications. We've got medications that are specifically designed for that. So lots to do prevention, lots to do for maintenance. And then if you are at high risk, so women who are smokers, drink too much, have a family history, had a fracture after age 40, we will do an earlier bone density in these women if they give us a clue that there's something going on that we need to be worried about. We will do it earlier. If your certain medications are bone unfriendly, that can lead to an accelerated risk for bone loss. So again, the individualization of knowing about you and whether or not you need a bone density before age 65. Everybody needs a bone density at age 65, and men too are at risk for bone loss later in life because they don't have the estrogen deficiency we do, but they are as well because they begin to lose androgen, and androgen is peripherally converted in men to estrogen, and that maintains their bone density. As far as heart health is concerned, again, smoking, terrible, lifestyle, being overweight, diabetes, lack of exercise, all of, family history, uncontrolled hypertension. All of these are risk factors for heart disease. And again, it's all about diet and lifestyle, making sure that we aggressively treat risk factors as identified. If you have high blood pressure, you need to be treated to target, know your number, know what your blood pressure is. We need to know what your cholesterol is, what your bad cholesterol is, what your very bad cholesterol is. We need to figure out based on family history whether or not we need to jump in with treatment more than just lifestyle and diet. So, you want to be heart savvy, you want to be bone savvy. And there are many strategies that you can use to first prevent, then maintain, and then treat if you must.
So, and metformin?
So metformin is, typically for people who don't know what metformin is, metformin was a drug that typically was used for first line therapy for diabetes, a very useful drug to promote insulin secretion from the pancreas. And it still is the baseline of much of our treatment. We also use metformin in polycystic ovarian disease. It has other endocrine indications. And metformin was looked at for a very long time as whether or not it could be the fountain of youth, whether or not metformin would delay aging. The jury is out on that. We don't use metformin as sort of an age-related preventive therapy, but it does have other indications other than diabetes alone. And again, it's individualization, but it certainly doesn't replace menopausal therapy for hot flashes or many of the other strategies that we use. It doesn't have any proven cardiac protection directly. Ozempic now has an indication for heart failure in individuals at risk. It's got a broader indication than just the weight loss. But, there are other medications that we use for other reasons that have benefits.
Right. Okay. We're going to move into skin.
Yes.
Yes.
So, and I mean, one of the things, because I am menopausal now, and you look in the mirror one day and all of a sudden you're like, wow, what happened? So it's interesting that we lose so much collagen.
It's such an interesting fact in terms of like the menopause world in general about collagen, that many women don't recognize that collagen is related to estrogen.
Yeah,
right.
We lose so much of our collagen. We lose about 20%.
Yeah. And it's fast, like within the
very,
first
very
few
fast.
years. Yeah.
That's right. And then we continue to lose about 2% more per year.
Mm-hmm.
And so collagen, like who am I telling, but I'm talking to people in general, collagen is really important for the elasticity in our skin.
Yeah.
If we think of our skin as a trampoline, it's sort of, we're losing the bounce, if you will. I like to think about that. We lose elastin. So we don't have the thickness that we have. The other thing that often happens to women is that they lose fat in their face.
Yes, that's actually almost a bigger issue, or the fat starts to fall. So so the collagen, then we start to get thinner skin, we get drier skin, we get more sensitive, irritation and allergy, even a bit of acne with the hormonal imbalances. And so I do have patients coming to me for all of those concerns, and they often ask also about hormone replacement for collagen. So I wanted, obviously we've sort of touched on that. We're not going to put somebody on hormone replacement for the,
and we don't even know, like once women get accelerated loss like right at that very beginning, and there's a greater correlation, which I was surprised to hear, between skin thickness and skin collagen content with years since menopause than there is with chronological aging alone. Once you've lost it, I know this, and this was like, and I will tell you that one of the exciting things that's happening in the menopause world is that now at our annual meetings we have experts talking to us about skin and about hearing and about vision and in related to menopause, because we don't have this narrow focus about it's just about hormones. That's not the focus at all. But once you've lost this collagen, going to menopausal hormone therapy is not going to give you the collagen back.
No. So that's right. So one of the things, two questions here. I often, and I wanted to give a shout out to our sponsor, Galderma. So Galderma is a company that makes fillers, hyaluronic acid fillers that help bring back. They're not giving you collagen, but hyaluronic acid is part of your dermis where the collagen resides. But the other big question I get asked, and I know my response, but obviously, if you have people coming to you presenting at the Menopause Society, collagen supplements.
First of all, I was far a big fan of hyaluronic acid.
Yeah.
Hyaluronic acid is, as we get older, we need to change our skin routine because you need to have something that's very hydrating. So
you're talking hyaluronic acid as a topical, not injection.
Topical. We'll talk about fillers in a minute.
Yeah.
But just in terms of taking care of your skin, every woman can use hyaluronic acid. It's very hydrating. I'm sure you talk about this all the time.
Yeah.
And it can help you with your skin and your texture changes. And, young women don't use serum. Older women probably need to use a serum. So that's why they see you. And that's why I refer to you, because we definitely need help. There's no question.
Right.
As far as fillers are concerned, it is cosmetic. It's temporary. And I think, I always say to women, do it for the right reason.
Exactly.
Do it for you. You're not doing it for anybody else other than you. You're doing it how you feel about yourself, and you're, great. That's all part of it. But as far as collagen supplements are concerned, we just don't really have any data to suggest that if you take a collagen supplement, it's going to turn back time.
Yeah, I think there is there are some small studies that are not robust, and again, it's not harmful. I usually recommend marine over bovine, just because for various reasons, and I don't think I put it in my coffee. In the morning, it's a powder.
For all of these things, I say to women that a lot of these things in the alternative or the natural market that lack evidence, and some of them lack safety, which is really an issue. The first thing we want to know is that regardless if we cannot answer the benefit question, we want to answer the harm question.
The safety question. Absolutely.
You want to make sure that something is safe and that there's no harm equation.
Yeah.
And then, the same way, like there's no harm in doing yoga, and there's no harm in any of these things. I don't know that it's going to
Well, you
help
can
you.
hurt your back in yoga. I've
True.
done that.
And,
So
and I've had pickleball catastrophes that I keep telling the women in my life, be careful about running backwards. It's not running backwards. It's not such a good thing.
it's so interesting. I'm going to listen to this over and over again to get the information. And I was on a group chat with some old girlfriends from high school, and one of them is having these terrible symptoms. And there's 5 of us on the chat, and everyone is chiming in with different things. And, well, I'm on this and I'm on this and I'm
That's
doing
the
this. And I
problem.
just said, and what I said is, it's very individual. You just have to see your doctor. It's incredible. And,
You're talking about menopause?
menopause.
Menopause. Okay.
She has menopause symptoms, one friend, and it's amazing all the different
And why
information.
do you think? Because there's so much information. We're going to get to that, but yeah.
So
Well, I
much,
also think that you've got to find a practitioner who's educated
right.
and who can partner with you, because a lot of I hate to say it, but it's true. A lot of healthcare practitioners are not educated,
Yeah.
and they'll often say to women, "Don't worry, it's going to go away."
Right.
They'll just sort of poo poo, like, don't worry about it.
That's not good either. That's actually bad. You
Well,
say, I'm
terrible.
not trained in this. I'm going to send
Terrible.
you to somebody who is, because that's a disservice to women.
Yes.
It's a complete
The most
disservice.
important thing about your physician is that they need to know what they don't know.
Well, that goes without saying. And I think we already talked about this, but do you think somebody who does a couple courses online or the NAM certification is
It's a start.
qualified?
It's
a
a
start.
start,
It's a
and
start.
at least they're living in that world, so they know what they don't know, and they
Okay.
know who they can refer to if they need to refer to.
Okay.
Yeah.
All right.
And
It's a good start.
it's also amazing seeing some of our friends suffer for a really long time. We were out for dinner with a friend. She must have had 5 hot flashes in 15
Oh, yeah.
minutes, drenched, and her doctor just he wasn't listening.
Well, then
And
she's got to go back. Well, it's very hard to find a doctor. I'm not discarding that,
Mhm.
but she's got to go back and say, you need to refer me. And even I see women all the time who are referred to me by other primary care doctors who will say to me, I've got a woman with this and I'm not comfortable.
Yep.
I don't know enough to know about treating her.
Yeah.
And I make sure to send a very detailed letter back so they understand what I'm doing, why I'm doing it. And it's not only that their patient is getting care, but they too are sort of getting an education in the consult letter as to why we did what we did.
Mm-hmm.
So I think it's, you go back and you have to advocate for yourself and say, if you had a broken leg and somebody said, don't worry about it, it's going to mend itself. I don't accept that. You'd say, I need to see an orthopedic guy. I need to see somebody who's going to do something about this. I think you need to say that I need to see someone who's well-versed in menopause.
So I think for the listeners, yeah, if you're having that experience like we had with our friend, and your family doctor's like, oh, it'll go away, or press them and say, if you don't know, can you send me to somebody? And if you can't, if they don't, try to find somebody with, maybe start off with looking for NAMs.
You can go onto the Menopause Society website. It's now called the Menopause Society, and you can look for a credentialed menopause expert in your area. That's how a lot of women find me.
Yeah.
But you can, and I think that you have to advocate yourself. You don't have to be rude or nasty about it. You need to be able to say, sometimes patients will ask me something, and I'll say, that really is out of my area of expertise. But let's check this out. Let's investigate this. And sometimes when I'm not sure, sometimes I get asked really outlandish things that I'm not really sure. I'll even say to them, look, you need to let me do a little research project here.
Yeah, I do that all the time.
I don't know about this.
Mm-hmm.
So you need to know what you don't know. And I don't think you need to be rude. I think you can say, to a healthcare practitioner, I really would like another opinion. I'd like to see somebody who's a little bit more well-versed in menopause.
Right.
And if you'll have a list and a few names of your own, then all the more power to you.
So we're going to finish off with sort of a controversial topic. We've sort of touched on it a little bit, but the misinformation that's out there on social media.
Yeah.
So, I mean, I'm on social media partly because I've found over the last 10 years in particular, if I'm not part of the conversation, I've got to be part of the conversation. So, there's so many influencers with no medical background giving claims of curing menopause, pushing expensive. I loved what you said before. If you're on a website that's information based, but they're trying to sell you something, go elsewhere.
So my tip to women is that the last 3 letters should be .org or .edu. Those are usually websites that are, academically based, or know that you're going on to something like the Canadian Menopause website or the Menopause Society's website or the International Menopause Society website that are not influenced by pharma, and are, for example, on both the Menopause Society's webpage and the International Menopause Society, I do videos. And I do hundreds of these, and I do them for experts, which you have to be a member to see. And then I do them for women. So I'll interview an expert twice, one at a level that's designed for healthcare practitioners, and one that is for women to know what this person is talking about. And they're free and they're available, and we have meno notes. And we keep them short and at a level that's easy to understand. So at least it can even give you questions to ask your own healthcare practitioner that you can, take it and write down notes.
Yeah, that's great.
Lots of informational pamphlets. So you want to know where you are going to get information.
I love the tip of .org or .edu. That's great, because there's just so much, and it takes up so much of our time too as physicians sometimes. Like I find it's a bit, I've learned a few things from you.
Something comes up, if you're not specifically like typing in International Menopause Society and it comes up first, but if you put in menopause, often the first few things that come up are not the sites that you want to go to.
No, they're Google sponsored. They're sponsored.
Yeah,
they're sponsored. Yeah.
Well, I think we covered it. Is there anything you want to add?
So. Well, I think
I want women to sort of walk away from having experiences like this, being sort of empowered and educated.
Yes.
Even if it's empowered and educated, just to say, I need to ask some questions. I always tell women that the only dumb question is the one that you don't ask.
Right.
I say that to my kids. I tell my kids that.
There's no dumb question. Your relationship should be a shared partnership. So you should be able to collaborate with your healthcare practitioner to ask questions and get answers, or be pointed in the right direction to get an answer. And it's got to be a conversation. Women come in and ask me things that I don't support, but I want to know where they got the information, why they feel that way, and I will do my best either to sort of demystify if there's an area that's completely wrong that they've picked up on social media that doesn't apply to them. But it's got to be respectful and mutually respectful.
Yeah. Well, listen, I am so lucky that I have such an incredible physician.
I'm lucky with my patients. I'm lucky with my patients because, and I'm sure you are too, because there are patients that do want to collaborate with you and do want to work with you and do want to, become educated with you. And I'm always telling patients, we're not changing our mind. We're evolving as time goes on, like just as we did with the menopause statements. We evolve as more information comes.
Oh, medicine is that's the whole point. It's lifelong learning, for us and for our patients. Well, thank you so much for taking the time. I know you're very busy. I think this was very useful. And, part of the reason we started this, or I really wanted to, because I wanted to address misinformation. And, you can't really get enough in a 30-second reel. A minute, you need a nuanced conversation.
140 characters. No,
you can't. Yeah. You can't. And so thank you again for taking the time with us.
Marla, thank you.
Thanks for having me, because I think it's such an important topic, and really getting women to understand their skin, their body, their health, just being female, pay attention. And it's never too late to get educated and change your life and, or add to your life. So thanks for having me.
Thank you so, so much.
See you next time on Skin to It podcast. Don't forget to subscribe.
Please let us know what you thought of today's episode.
If you have any questions or thoughts, send me a message on social at Dr. Sandy Skotnicki. And don't forget, all the links and resources we mentioned are in the show notes.
And if you haven't already, please subscribe and leave us a review. It helps us to bring you the content you love.
Until next time, take care, and we'll see you next week on Skin to It.